Let's move on. Barbara, is that...
Yes, that's fine.
Bill.
Thank you, Chair. The business plan deliver also the things we've said we do as an organisation are covered in paragraphs 18 to 28 in the narrative, and also they're summarised in the delivery status tables in the annex. I think that's self-explanatory. I don't intend to go into that in much more detail. I would pick out just two things. I think, first of all, a reference to David's Chief Executive's report where he was talking about the strategy work that we launched right at the start. You remember just about the time of the last board meeting, and that's been carrying on a lot of energy since then, with yesterday's AGM being a real staging post. And the other thing I'd pick out is it's actually in the status report, and it's the discussions we're having with Monitor around choice and competition and how best they can be applied in healthcare to improve outcomes for patients, including better experience. That's taken a bit longer than we'd hoped. We had hoped between us to be able to put out some guidance early in the summer. I think that probably reflects that it's one of the areas where there is a paucity of evidence. We're committed to be a system that does work on evidence, and in this area, even taking from the international experience, the direct evidence of where best competition and choice can work to improve outcomes is fairly limited. The approach we're now adopting with Monitor is to actively seek out, collect and publish that evidence as we go along, so we can be a learning organisation, and the more we discover about where these forces really work for patients, and just as importantly where they don't, we'll be making that public so that we can give the best possible guidance to commissioners and indeed to providers in the NHS.
It is so important to get away from ideological preconceptions and to get to a much more pragmatic focus around the needs of patients. Good. Thank you for that. May we turn to Jo?
Yes, thank you, Chair. If I can just take us briefly to Section D of the pack of material. This section's headed Organisational Health, and I think I just ought to point out, I know the board appreciates this, but for the people in the room and on the live stream, the organisation we're talking about is NHS England. So whilst the majority of the pack looks outwards and looks at the performance of the whole NHS, this bit of the pack's about the performance of NHS England. It's important, I think, because I talked to somebody at the AGM last night who thought we employed the 1.3 million staff in the NHS, and this is about the workforce bits I'm going to talk about are about the 6,000 staff that NHS England employs. And the bit I'd like to focus on, given the time constraints, is the results of the first staff barometer. And what you've got here is the high-level results. The detailed results will be looked at in the Remuneration Committee. As Malcolm says, that's where we do most of the work of the board in committee. In previous meetings, we've talked about the difficult transition process that staff have just been through. We've talked about that quite a lot. We decided we wanted to take the temperature of the organisation quite early on to get a sense of how people were feeling. And we've been working on this with Michael West, who's an academic from Lancaster University, who's worked over the last 10 years on the bigger NHS survey and has done some very interesting work linking staff experience and patient experience in the NHS. What his research proves is that there is a very direct correlation between staff experience and patient experience. And in fact, the experience of staff in organisations is one of the strongest determinants of patient mortality in organisations. It's very interesting stuff. So what we've done here, rather than ask people to do the whole survey, we extracted questions from the staff survey that we thought were relevant to an organisation that was in a start-up mode, which has allowed us to do comparisons against the wider NHS workforce survey results. So you'll see in the little graphs on page 8, you can see our results benchmarked against the wider staff survey results. So as well as the questions, we also gave people the chance to give us free text comments, and we got quite a lot of those. And you'll see at the bottom of page 7, we've kind of correlated those, had a look at them and put them into 3 categories. We think there are about 3 sorts of things people were telling us about. One was getting the basics right, sorting out IT, sorting out accommodation, sorting out basic policies and processes. The second one was about clarity of roles and objectives, which I guess is probably not unusual in a new organisation, but still you can see from the quantitative data that's an area where we need to do some work. And the third one was about tackling bureaucracy and hierarchy. So it's the first time we've ever had a national organisation like this, and some of our processes I think are a bit clunky at the moment. So it was about that really. And I do want to say thank you very much to everyone that filled it in. You'll see the response rate wasn't marvellous, and one of the things we need to do is get the response rate up. It was about 36% of the workforce. The important thing, of course, is what we do now, I think, what we do with this. And one of the ways in which we'll get the response rate up is showing people that we're listening and that we're doing something about it. So what has happened since we did the barometer is that each national directorate, each region and each area team has been given their own results. And we've asked each director responsible for those units within the organisation to sit down with the staff, share the results and do their own action plan, and to put those action plans on the intranet. So they're not all on there yet, but by the time we've finished, there'll be an action plan on the intranet for each region, each area team and each national directorate. There's also a national action plan on there, which explains the programme of work that we're going to oversee at national level. We've set up a group that David chairs that's looking at 7 priority areas, and that's based on what people told us in the staff barometer and a meeting that we had to review the OD strategy, which Victor and Bill and David were involved in. The 7 areas, very briefly, are accelerating the PDR process. That's really important to getting clarity of roles and objectives for people. Improving internal communications. Agile working, by which we mean making sure people have got the right accommodation and the IT kit to be able to do their jobs. Leadership, getting team working more effective across the organisation. We've previously called that matrix working. We're starting to call it team working now. Health and well-being of staff, and establishing a network of workplace champions, excellent organisation champions. So at least one person in every building that we have staff who will be a workplace champion that we can have a 2-way dialogue with, and we can get real-time feedback about what we're doing. And each of those 7 work streams we're going to ask an area director to lead, because most of the staff are in area teams, and because area directors are very experienced, a lot of them have been chief executives and have done this in their own organisations, and each one will be supported by a national director. And we had the first meeting of that group earlier this week, and the next one's in about a month's time.
Margaret.
Just one question. It's a really great piece of analysis, really helpful, thank you. I just had one question that was about staff engagement and how you're measuring that, because there appears to be a good level of staff engagement from the graph here, yeah. But the numbers of people who've actually participated must demonstrate a level of engagement, and that slightly conflicts with this.
Yeah, that's right. I think that's right. I mean, there are a series of questions. I think there are about 20 questions, and we split them. The analysts have split them into those headings. So the questions that fed the staff engagement graph were things like, I have opportunities to show initiative, to make suggestions, to make improvements, etc. But you're absolutely right. I mean, the executive team have had a conversation about, for the next one, which is later in the autumn, we really need to get the response rate up, because the validity of the results is only as good as the response rates.
Okay, thank you. Paul?
Just briefly then to pick out the financial highlights. So you'll see in the main text I've pulled out a few of them, but I'd refer you to section C and to the summary at page 15 in section C, which to me picks out the financial highlights in the clearest fashion. I'm going to distinguish really between CCG performance and the performance of the direct commissioners briefly. There are no variances of significance, as you can see in the CCGs overall, and indeed the risk analysis which each individual CCG now does and feeds to us suggests that any risks they have got, and they are particularly around predictable enough activity, and particularly acute activity and quick delivery, can actually be covered off by reserves and contingencies which they've quite rightly put into the plans as they constructed them. There are just two notes of caution I'd sound, I think, about CCG performance as it's summarised here. One of which is the very differential resilience of individual CCGs, which obviously gets masked in the totality of this. You'll be aware that we've got 9 CCGs who agreed a deficit plan with us because there just wasn't a credible way in which they were going to be able to live within their resources. There are another 14 CCGs who, in the risk analysis that they've submitted, have indicated that if all the risks materialise that they can see around them, they don't yet see enough mitigation to get themselves back up across the line. So we've got quite a mixed bag of CCG strengths. That should be no surprise to anyone from the discussions we've had already. And the second thing is the quality of QUIP delivery. I had intended to put the QUIP slide into this pack, and it will be in future ones, but it doesn't appear to have found its way into it. QUIP delivery, the delivery of savings from productivity and other types of improvement, is lagging a bit behind plan. It's at about 86% of plan, which historically is not a bad percentage, but we don't aim for 86% for obvious reasons. And whilst the CCGs are forecasting that they'll get that back up to about 94% by the end of the year, that's obviously quite a cause for concern. And if you dig a little bit deeper, the savings they're finding it most difficult to deliver, which we are now distinguishing carefully from other sorts of savings, are the transformational savings. I guess, again, there's no great surprise in those, but there is a performance which is pretty strong on the transactional stuff, the routine stuff, the kind of day in, day out stuff, rather weaker on the transformational stuff, which brings us a bit back to where David was in his introduction, which is that we've really got to sort of switch the dial up on the strategic change that we're trying to do, because it's becoming apparent that's the bit that's holding us back and will continue to hold us back. So that's really the CCGs. The direct commissioning is, and we said this when we talked about the plans earlier in the year, the area where the pressures were always going to be more difficult to meet than they are in the CCG sector. And it is true to say, if you just look at the trends there, that the combination of baseline issues that we've had in resolving the shift of business, as it were, from the PCT baselines into specialised commissioning, and in particular the limited visibility of activity, is giving our specialised commissioning teams a very big job of work to do to get a grip on their numbers, and then obviously to deliver within the budgets that they've got. So in the numbers you've got here, 4 of the 10 area teams are showing adverse variances, which are through here. The other 6 are flagging up in a similar fashion risks around that, which to a large extent they can mitigate once off through some combination of reserves and other measures. But there is quite a serious worry, I think, we've got about the ability to get all of that sorted out. It's fair to say we are prioritising a lot of action on the activity control side of things at the moment. Barbara is personally leading a big piece of work to try and, in the next few weeks, really get the visibility of that up and running to help us with that, but quite a bit of risk around there. And as you'd expect, that is also reflected in QUIP performance, which is weaker on the part of direct commissioners to date at about 70% than it was in the CCG. So we've got some work to do on QUIP as well. So the final thing to note then is that the running costs and programme costs of NHS England, which are in large measure the other line that you can see in there, are running very positively year to date. I don't take any particular message out of that. I think it's purely the phasing in which we take on our various activities in the year. So we'll see how that progresses during the course of the year. So in summary, significant challenges which we're addressing, particular challenges for the teams managing specialised commissioning. We're going to be carrying out a very in-depth stock take, as it were, around the month 6 numbers, which we work on in October, really to try and get an even more an even stronger handle on where the year is headed to, and potentially also trying to link through to the longer term work in terms of where the underlying trends are going. And obviously we'll bring that back to the board in November when we have the next financial update.
Thank you very much. Right, I think that concludes that item. Thank you very much, Paul. May we turn now to the final item on the agenda, which is the NHS England and CCG financial plans for 13-14. My apologies.
A couple of words on the board assurance framework.
Oh, okay, yes. Will you take us through that?
Yes, right.
Okay, I'm sorry. We'll just have a brief review of the board assurance framework.
Really just to say that, as we promised, there is an update on the board assurance framework and the strategic risks the board facing at the end of the performance report. I can confirm in process terms the Executive Risk Management Group is meeting monthly under Barbara's chairmanship, and Barbara may want to say a word at the end of this. And it is managing the strategic risks as well as hearing about any other risks that are brought to our attention from the organisation itself. Just two things I'd highlight from the report, two new strategic risks since we last met, both of them really about the newness still of the system. One we've called immaturity of some of the processes, and I think we've been hearing about some of that this morning. So when Joe was talking about getting our staff fully engaged as we brought on all the news, that's part of developing our process. Indeed, Paul was talking about the activity processes. So we're keeping a close eye now on the development of the processes which will help us deliver the right sort of outcomes for patients. And the second one is reflecting the discussion here at the board last time, and it's about our partnerships with other parts of the system. I know there was a concern that there are more players and therefore the potential for a more fragmented way of supporting better outcomes for patients. We're putting a lot of time into developing those relationships, and in that context I think having all of our partner organisations nationally signing up to the strategic call to action and participating very actively is a really important mitigation in aligning our goals and our priorities. So we've put those on the register because they're important, but we are actively managing them both, Chair.
Thank you very much.
Just as Chairman of the Risk Management Committee, I would just like to say I feel I can give the board increasing assurance that we've got in place all the systems and processes for identifying, assessing and managing risk, although I don't think we should underestimate the complexity, such a large organisation, geographically dispersed, and the need to marry the bottom-up identification of risk with that kind of strategic consideration at national level. We have had a couple of examples where I think this has really worked brilliantly. Paul alluded to the activity work, but it's actually the risk management systems which brought to our attention a few weeks ago the risks we were running because we didn't have the precise activity information, the visibility that we'd been used to in the old system. We were able to escalate that to the executive team, who were then able to put in place an urgent external assessment of what needed to be done to get us back on track for that. That work has now happened, and we've got a new project within NHS England to deliver better visibility. So that's just a practical example of where it's really working. I think we've a lot more to do on the risk management in terms of are we assessing and scoring risks equally, the way that different individuals do that. And I think we've more to do to work out how we present both to the board and the audit committee what you see, so that you are able to see the biggest risks and be in a position to either identify those risks or choose as a board or audit committee that there are further mitigating actions that you think should be taken. It's work in progress, but I think we are really beginning to get a good system in place.
Thank you.
It might be just dropping in as part of the framework that the Quality and Clinical Risk Committee met for the first time earlier this week with Cyril Chandler as the expert independent chair. And what we're thinking of doing is really three things. First of all, starting off by saying, are the processes for identifying clinical risk as they stand at the moment robust uniformly across NHS England. Second one is working on what continuous improvement of the outcomes would be. And the third one is trying to project forward and say what risks will come down the track at us because of ageing population and all of that, but take it in that sequence and get our own house in order first in one of the phrases. But I think that'll help with the framework.
I'm really pleased that committee's now got up and running after December's first meeting, as is the chair of the audit committee, and it's a very, very, very important underpinning for our business. Good. Okay, thank you very much. May we move now, Paul, please, to the final item?
Yes, I can keep this very brief, Malcolm. This is just a formal culmination of the process of plan making at CCG level and area team level. It's been through rigorous scrutiny by the regional teams and indeed by the central teams. The Ops Executive has worked hard on this, and finally the Finance and Investment Committee has spent a lot of its time looking at this in depth. So the plans which are in front of you and the comments on them which are in the narrative are there simply for you to note and formally approve, if you would, as a matter of record at this stage of the year.
May I invite the board to formally approve the plan? Thank you very much. That brings us to the end of business for this meeting. The only other business I have is to report that the next meeting of the board will be on the 8th of November at Rivergate House, Newbury Business Park in Berkshire. I now propose that I shall close the formal public meeting of the board, and the board will then shortly move into private session, as I indicated at the outset. May I, on behalf of the whole board, thank all those members of the public who have joined us this morning and have been able to observe the board in action, and I now declare this meeting closed. Thank you.